Hello. Today's topic is clinical examination of Waldayer. Now we will be going across various subtopics, namely OPD setup, history taking, then clinical examination of the patient per se, then a description on the various inflammatory disorders that can affect the components of the inner Waldayer ring, with specific reference to palatine tonsil, adenoid, tibial tonsil, and then investigations of all these conditions, and then management of the same. You'll also be seeing videos of commonly performed surgical procedures to alleviate the patient's symptoms caused by inflammation of Waldayer. Now let us go to the setup. In otolaryngology, you need to examine the cavity. To examine the cavity, you need to have lighting, proper lighting, and namely the examination setup and the lighting setup per se are of two types. One is the fixed Wolf's lamp, which has a container which is made up of stainless steel, and this container has small holes at the top. These holes help in the dissemination of heat from the container to the outside, keeps the bulb cool inside. And the bulb used for illumination is 100 watts milk white bulb. The milk white bulb will not have a filament seen outside. So if the filament is not seen outside, only the light will be thrown in front of the bull lamp. And this bull lamp has a planar convex lens in the front, which helps in throwing the light from within the container. And this is the headband, which is a mobile light source, which you can carry along. And currently, this is the popular lighting solution available. Now let us go to the most important component, the head mirror, which should be used along with the bull's lamp in order to throw light, reflect the light from the bull's lamp onto the patient. The head mirror is actually a concave mirror with a hole in the center. I'm pointing the full cursor, and this hole, center hole, is roughly about 2 centimeters in diameter. The focal length of this concave mirror is 10 inches, and it has two ball and socket joints at right angles, placed at right angles to each other. This helps in adjusting the mirror so that the light will be focused at its focal length, roughly 10 inches. Now let us go to the position of the patient. The patient is seated in front of the examiner. Ideally, the patient should be seated on a stool, and the patient should be seated approximately at the same level of the examiner. The bullseye lamp should be placed close to the left shoulder of the patient, and the patient's legs should be placed to one side of the examiner. The distance between the patient and the doctor is roughly 8 inches. So this falls within the range of focal length of the head mirror, which is roughly 10 inches. The mirror is placed over the right eye in such a way the mirror touches the tip of the nose. So the right eye will be seeing through the hole. So to ideally focus the head mirror, you need to close the left eye and see the patient through the right eye, and then slowly open the left eye. The entire field will come into view. The left eye views the patient from outside the confines of the mirror. The mirror is adjusted in such a way the right eye always sees through the hole and the left eye sees from outside. Now let us come to history taking. The patient's common complaints which brings the patient to a doctor is going to be pain in the throat, difficulty in swallowing, pain in the ear block or hard of hearing, nasal block, nasal discharge. We will see the relevant history of all these complaints one by one. Let us start with pain in the throat. If the patient complains of burning pain in the throat, it indicates pharyngitis. Pharyngitis is nothing but inflammation of the submucosal lymphoid tissue seen in the posterior pharyngeal wall. So classically, the term burning sensation, the patient says pain is burning in nature, it goes without saying the patient is suffering from pharyngitis. Then second common pain which can occur is pain during swallowing. It is also known as odynophagia. Odynophagia is the term which we use in medical parlance to describe painful swallowing. Some old generation examiner are fond of this particular question. They will ask you during your clinical case presentation, what is the commonest cause of odynophagia? Then you need to say it is tuberculous laryngitis. Then if the pain is lancinating in nature, lancinating is stabbing. So if the pain is lancinating in nature, it indicates glossopharyngeal neuralgia. The posterior pharyngeal wall and the tonsil is supplied by the glossopharyngeal nerve. Now let us come to the second common complaint is difficulty in swallowing. The difficulty in swallowing could be due to the size of the tonsil. The larger the size of the tonsil, more difficult the swallowing becomes. And what happens is if the tonsil touches each other, that is known as a kissing tonsil, the swallowing becomes really problematic. Kissing tonsil is actually caused by infectious mononucleosis, and the term kissing is has been given to this particular condition to indicate that it is caused by infectious mononucleosis. As you all know, infectious mononucleosis is transmitted by kissing, and it's also known as Kissing's disease. So tonsillar hypertrophy due to infectious mononucleosis is also known as kissing tonsil. Then these children, if the children suffer from adenotonsillitis, they have a tendency to vomit immediately after being fed with milk or water. Why this happens? Normally, if there is going to be nasal block due to adenoid hypertrophy, these children are known to breathe through the mouth. If they breathe through the mouth, there is always a tendency to swallow air into the stomach. The air gets swallowed into the stomach, and later the child's stomach is filled with air. On top of it, the baby is being fed with milk or water. What happens is the air starts to float upwards. Because liquid is heavier, air is lighter, it tends to float upwards, and it pushes the cricopharynx and the lower esophageal sphincter and cricopharynx open, and the patient immediately vomits. So, if the child is brought to the doctor with complaints of tendency to vomit immediately after being fed with milk, it goes without saying the child is having adenoid enlargement or adenoid hypertrophy. Then patient may have pain when swallowing. If there is pain while swallowing, then patient may be, even they fear the very act of swallowing, they may not eat at all. So difficulty in swallowing can also be caused by painful sensation when the pharyngeal musculature contracts when the patient attempts to swallow. Now let us come to the third component, which is pain in the ear. Pain in the ear is classically known as otalgia. The commonest cause of pain in the ear due to inflammatory lesions involving the Waldayer thing is the referred pain. Referred pain is, as you all know, the posterior pharyngeal wall, tonsil are all supplied by glossopharyngeal nerve. The same glossopharyngeal nerve also supplies the promontory of the middle ear. The pain localization of glossopharyngeal nerve is actually very, very poor. So the brain gets confused from where the pain is originating from. Even though pain is originating from the tonsil, posterior pharyngeal wall, it is being perceived as pain originating from the middle ear, promontory, because the ear happens to be the most sensitive of the organ. So brain has a tendency to interpret this pain and attribute it to sensation coming from the ear. That is the amount of importance your brain gives to the sense of hearing. And then pain in ear can be due to otalgia, real true otalgia. True otalgia is caused by, what happens is, the components of inner Waldayer ring are as follows. One is the parapalatine tonsil. Next comes a posterior pharyngeal wall group of lymphatic tissue. Then comes Luschka's tonsil of adenoid. And then on either side, you have a eustachian tube opening, pharyngeal end of the eustachian tube opening. Guarding the pharyngeal end of the eustachian tube opening are a pair of tonsil. These are known as tubal tonsil of Gerlach. So these inner Waldayer ring component are in connection with each other submucosally. So they are all interconnected. So if one structure gets infected and enlarges, it also causes simultaneous infection to the other structures also. So these tubal tonsil of Gerlach, when it gets enlarged, it causes blocking sensation, eustachian tube. So the eustachian tube will get blocked. The mid-layer cavity ventilation process is affected. the drainage function of the eustachian tube is affected. So this can cause secretory otitis media or acute otitis media. So this picture shows the secretory otitis media where you see air bubbles in the middle ear cavity, which is clearly visible via a thinned out eardrum. Here you see a bulging, inflamed reddish drum, a class reddish drum, which is actually a classic feature of acute otitis media. Next comes the nasal block. So nasal block is commonly seen in patients with adenoid hypertrophy. The adenoid hypertrophy invariably causes nasal block to both sides of the nose. And nasal block can also be caused by rhinosinusitis, which in fact could cause adenoid hypertrophy because the infected material from the sinuses drains through the nasopharynx and the entire adenoid will be clothed with infected secretions from the nose and sinuses. So it causes adenoid hypertrophy. So adenoid hypertrophy can also be caused due to rhinosinusitis. So whenever you examine a patient with rhinosinusitis, adult patient with rhinosinusitis, you always suspect adenoid hypertrophy in those patients. It doesn't mean you need to perform adenoid surgery in an adult. If you take care of the rhinosinusitis, adenoid also will reduce its size and become normal. Now let us come to the next complaint. It's a nasal discharge. The quality of the discharge is very important. Normally it is mucoid in nature. Sometimes in the case of the purulent bacterial sinusitis, the discharge could be mucopurulent. The mucoid discharge mixed with pus. It could be yellowish white in color. Mucoid is purely white in color. Discharge could be serous. Serous discharge is commonly seen in allergic rhinitis and vasomotor rhinitis. Then serosanguinous discharge is commonly seen in acute rhinosinusitis where the nasal discharge is tinged with blood. Blood tinged discharge is known as serosanguinous nasal discharge. Then watery discharge is again seen in CSF rhinorrhea. Let us go to the past history. You need to ask the patient whether there are any episodes of previous recurrent attacks of fever, any previous history of joint pain, any previous history of skin rashes, any previous history of burning micturition, any history of bleeding diagnosis. They should be clearly asked because if the patient is going to have recurrent fever, it goes without saying the patient child could be suffering from recurrent tonsillitis, recurrent adenotonsillitis. And mind you, we should be bothered about tonsillitis in children because it could harbor beta hemolytic streptococcus, which is known to cause rheumatic fever. Rheumatic fever, as you all know, can cause pericarditis, can cause valvular disease, can cause joint pain, can cause skin rashes. And beta hemolytic streptococcus also can cause acute glomerulonephritis. That is the reason why you should specifically ask for history of burning micturition. And history of skin rashes, again, you should ask in patients with tonsillar infection because rheumatic fever also manifests with skin rashes. In infectious mononucleosis, when you treat the patient adenotonsillitis due to infectious mononucleosis with ampicillin, these children can develop skin rashes. So it is important to not to prescribe ampicillin in children with huge tonsillar enlargement because if it is due to infectious mononucleosis, it can cause skin rashes. Then you should specifically ask for history of bleeding diathesis because this history is vital when you decide to operate the patient. If the patient is going to have bleeding diathesis, it will be very difficult to control bleeding. So that history should be specifically sought for. Then let us go to the personal history. Personal history usually relevant only for adults. History of smoking, history of alcohol can be sought. But in children, this is not so relevant. Let us go to examination. Now, this is how we examine the patient for inflammatory disorders of inner wall testing. You examine the oral cavity, then you go ahead and examine the oropharynx. Now, let us go to the oral cavity. These are the areas of oral cavity which your examination should focus on: lips, teeth, gums, tongue, palate, both hard and soft palate, floor of the mouth, and cheeks. Now these are the areas of oropharynx which you need to focus on. One is the uvula, number 2 is soft palate, anterior and posterior tonsillar pillars, palatine tonsils, and posterior pharyngeal. Supposing if you examine the uvula, on examination you find a bifoot uvula similar to as shown in the picture. It indicates this child or individual could have a submucosal cleft palate or occult cleft palate. This means that the bony portion of the palatine bone has not fused in the midline. There is a deficit in the bony portion of the palatine bone. But the mucosa covering the cleft is completely closed. So the patient may not overtly show evidence of cleft palate, but still submucosally the palate could be divided into two because the bone has not joined in the midline. This is where you see. This is the cleft, submucosal cleft which you see. So why it is important? Suppose you going to do adenodectomy in these children, what is likely to happen is the removal of adenoid pad of tissue will cause regurgitation, prolonged nasal regurgitation when the child attempts to consume liquids. So that will be a real problem. So you need to take care while you do adenodectomy in patients with submucosal cleft palate. It is always better to remove a small amount of adenoid in the nasopharynx in these children because at a later date, the child may not suffer from nasal regurgitation of liquids. Why this nasal regurgitation occurs in these patients is because the tensor veli palatine muscle is not inserted normally in this patient. It has an abnormal insertion point. So when due to the abnormal insertion point, the nasopharynx does not close adequately to seal off the nasopharynx from the oropharynx when the child attempts to consume liquids. So the adenoid pad of fat is actually a compensatory mechanism. Sorry, adenoid pad of tissue is actually a compensatory mechanism which occludes the nasopharynx and closes it in such a way that nasal regurgitation does not occur. By removing the adenoid tissue totally, you will be opening up the nasopharynx to the liquids when the child starts to drink fluids after the surgery. And then you need to concentrate both on the anterior and posterior pillars. Anterior pillar, you look for redness, it's known as semilunar sign. The classic feature of chronic tonsillitis is presence of semilunar sign in the anterior pillar. It is also known as semilunar sign. And then look at the tonsil, note the enlargement of the tonsil, the grade of enlargement of tonsil I will narrate later. Then you look for the inflammation of the posterior pharyngeal wall lymphatics. Submucosal lymphatics present in the posterior pharyngeal wall. Now here, this is actually how you grade the tonsillar enlargement. Here, grade 1, the tonsil is normally within the pillars. You see both the anterior and posterior pillars clearly. Anterior pillar is formed by palatoblastus muscle. Posterior pillar is formed by palatopharyngeal muscle. And these muscles are covered by overlaying mucosa or cutting mucosa. So in grade 2 tonsils, what happens is this grade 2 enlargement, there will be the tonsil will be enlarged so as to reach 50% of the distance between the base of the uvula and anterior pillar. As shown here, this is grade 2. The 50% crosses 50% of the distance between the base of the uvula and the anterior pillar. In grade 3 enlargement, it exceeds 50%. It just crosses the 50% mark. Here, this within the 50%. Like grade 2, it lies within the 50% distance. Here, crosses the 50% distance between the base of the uvula and anterior pillar. And in grade 4, both tonsils get into contact midline, known as kissing tonsil. Let us come to the embryology of tonsil. Tonsil arises from the ventral portion of the second pharyngeal pouch. This pouch is also known as sinus tonsillaris. This is actually the pouch, palatine tonsil, second pouch, ventral portion, second pouch from where palatine tonsil arises. Here, this sinus tonsillaris can be present as a remnant close to the superior part of the tonsil in some patients. So when you put the tongue depressor, if you see a small opening just above the superior part of the tonsil, that is nothing but persistent sinus tonsillaris, as is shown in this photograph. Now let us come to the blood supply of the tonsil. The tonsil is a highly vascular organ. It receives blood supply from tonsillar branch of facial artery, tonsillar branch of lingual artery, tonsillar branch of ascending pharyngeal artery, and then tonsillar branch from the greater palatine artery. So it's highly vascular structure. The lateral surface of the tonsil is also known as the tonsillar bed. There are vital structures lying in the tonsillar bed. The most important being pharyngobasilar fascia, buccopharyngeal fascia, the constrictor muscles of the pharynx, and then the great vessels, namely the internal carotid artery, is on the jugular vein. The great vessels are on close to the tonsillar bed. It is very easy to traumatize these vital structures while tonsillectomy is being proceeded. So you've got to be very careful. After removing the tonsillar bed structure should not be breached. Tonsillar bed should be respected. It should not be breached because the vital structures like glossopharyngeal nerve, internal carotid artery, then the pharyngeal constrictors, buccopharyngeal and pharyngobasilar fascia are all forming the bed of the tonsil. Venous drainage from the tonsil occurs via the paratonsillar vein. These vessels pass to the pharyngeal plexus or to the facial vein after piercing the superior constrictor muscle. So the venous drainage will have to travel through the paratonsillar vein and they need to reach the pharyngeal plexus or the facial vein. But to reach that area, it should pierce the superior constrictor muscle, which forms one of the structures of the tonsillar vein. Lymphatic vessels from the tonsil again has to pierce the buccopharyngeal fascia to pass to the upper deep cervical nodes, particularly the jugular digastric node. The jugular digastric node group, which receives lymphatic supply from the tonsil, is also specifically known as the Wood's node. Now, inflammation involving the inner wall skin can be caused by viral infections, bacterial infections, fungal infections, and parasites. Let us start with the viruses. Viruses commonly affecting the tonsil include influenza virus, parainfluenza virus, adenovirus, and rhinovirus. Let us come to the bacteria. So, bacterial infection of the tonsil is streptococcal pneumonia, beta hemolytic streptococcal infection, which we should always be aware because of its potential ability to cause complications. Then you have staphylococcus, pneumococcus, Haemophilus influenza, diphtheria. Commonly, bacterial infection or polymicrobial in these children. So there is being polymicrobial, there is always a synergistic relationship between these organisms. Now, let us come to inflammation of the palatine tonsil, which is also known as tonsillitis. Acute tonsillitis is defined as inflammation involving the tonsil lasting less than 3 weeks in duration. So, acute tonsillitis is inflammation or infection of the tonsil lasting for less than 3 weeks in duration. It is commonly caused by viral infection. It can involve the mucosa, it can involve the crypts of the tonsil, it can involve the follicles, or it can involve the parenchyma of the tonsils. Let us go into the classification of acute tonsillitis. Acute tonsillitis can be classified into acute catarrhal tonsillitis, cryptic tonsillitis, acute follicular tonsillitis, acute parenchymatous tonsillitis. So let us look into all these 4 types of acute tonsillitis in detail. The term acute catarrhal tonsillitis indicates a viral infection of the upper respiratory tract which involves the mucosa of the tonsil. Acute catarrhal tonsillitis indicates a viral infection involving the upper respiratory tract involving the mucosa of the tonsil. So acute catarrhal tonsillitis is usually viral in nature. Then comes the cryptic tonsillitis. This is actually the involvement of infection in the crypts of the tonsil. So this is known as cryptic tonsillitis. The word crypt comes from the Greek word cryptos, which means hidden. There is an interesting aspect to this cryptic tonsillitis. You can see here. Bacteria and food remnants can rest inside these tonsillar crypts, and they can cause infection, gram-negative infection, anaerobic infection, and ultimately lead to tonsillar lith formation. Tonsillar lith is nothing like nothing but a stone-like tissue, stone-like structure seen within the tonsil. Tonsillar lith is usually seen in cryptic tonsillitis. Here, both aerobic and anaerobic organisms are clearly seen in culture. Gram-negative organisms also have been isolated. Anaerobic bacteria are known to produce sulfur compound like hydrogen sulfide or methyl mercaptan. So these release of these chemicals can cause foul breath or halitosis. So halitosis in acute cryptic tonsillitis is caused due to release of hydrogen sulfide and methyl mercaptan by the anaerobic bacteria. Let us see the clinical features of acute cryptic tonsillitis. So these children, they have halitosis. This is due to the chemicals released by anaerobic organisms, sore throat, ear pain, swelling of the tonsil, sometimes presence of tonsillar lith. Next comes acute follicular tonsillitis. This condition is actually spread of infection from the crypts to the surrounding follicles. So the infection from the crypts are started to spread to the tonsillar follicle. This condition is classically caused by beta hemolytic streptococcus. So if you see a tonsil like this as shown in the photograph, it indicates acute follicular tonsillitis. Acute follicular tonsillitis is commonly seen in beta hemolytic streptococcal infection. I have already stressed the importance of this infection, the potential complications it can cause. So it is important that you treat these children aggressively, rather aggressively. The clinical features of acute follicular tonsillitis include enlargement of the tonsil, reddened tonsil, crypts are filled with yellowish exudate. There is presence of enlarged Wood's node, cervical adenitis. Then there could be painful swallowing, rhodinophagia. These children can have fever, they can have weakness, they can have fetor. Fetor or foul breath is caused by enlarged adenoid tissue causing nasal block. Whenever there is a nasal block, I already told you, the patient starts to breathe through the mouth. When the patient starts to breathe through the mouth, there will be drying of the oral mucosa. The oral mucosa is not designed to humidify air. So when there is drying of oral mucosa, foul breath will result. This is commonly seen early in the morning because during the night time, when the patient is sleeping, the saliva production is at the basal lowest limit. So when the patient is breathing through the mouth during the entire night time, the oral cavity will become dry, and the next day morning, the patient will get up with a foul breath. Now let us come to acute parenchymatous tonsillitis. Here, this is actually caused by secondary bacterial infection. Secondary bacterial infection after the virus is infected. This is the secondary bacterial infection supervenes. Here, the secondary bacterial infection invades the crypts and it spreads to the tonsillar parenchyma. The bacterial infection invades the crypts and spreads to the parenchyma of the tonsil. This is acute parenchymatous tonsillitis. Here you will see a diffuse enlargement of the tonsil with reddish mucosa over it. The crypts cannot be clearly seen. The follicles cannot be clearly seen. So this is how the tonsil will look like in acute parenchymatous tonsillitis. Let us come to chronic tonsillitis. Chronic tonsillitis is usually defined as tonsillar infection lasting more than 3 weeks in duration. These patients symptomatically they are suffering from milder symptoms when compared to children with acute tonsillitis, and tonsils are enlarged and the follicles are not prominent. So the infection is found within the substance of the tonsil. So infection is commonly found within the substance of the tonsil. The infection in the patient with chronic tonsillitis is actually polymicrobial in nature with gram-negative organisms predominating. Anaerobic organisms and gram-negative organisms are predominantly seen in children with chronic tonsillitis. Surgery is commonly indicated in these patients because it is difficult to eradicate gram-negative and anaerobic organisms from the tonsil by giving antibiotics alone. what are all the features of chronic tonsillitis? That is, these children will have tonsillar enlargement. There will be semilunar congestion of the anterior pillar, that is also known as lunar sign, and then enlarged, non-tender, mobile upper deep jugular digastric node or Wood's node. So the Wood's node or jugular digastric node will be enlarged, non-tender, and mobile. The squeeze test or Irving Mood sign is positive. How will you perform squeeze test? This test is performed by applying pressure to the anterior pillar of the tonsil, sustained gentle pressure using a tongue depressor. If the whitish material gets extruded from the crypts, it is considered to be positive. So, presence of positive Irving Mood sign is a classic feature of chronic tonsillitis. Classification of chronic tonsillitis include chronic follicular tonsillitis, chronic parenchymatous tonsillitis, chronic fibrotic tonsillitis, and membranous tonsillitis. So let us go to chronic follicular tonsillitis. So in these, the tonsillar crypts are usually filled with cheesy material. They appear as yellowish spots. These patients, they have tonsillar enlargement associated with prominent follicles. Whitish material can be seen coming out of the follicles when the anterior pillars are gently pressed with the tongue depressor. The whitish material can be seen extruding from the follicle. This is known as the positive Irving Mood sign, and this test is known as squeeze test. Inflammation and blockage of the crypta magna, which is the largest of the crypt of the tonsil, can lead to quinsy. This is actually the old theory. Quinsy is otherwise known as peritonsillar abscess. Our old theory says inflammation and blockage of crypta magna, that is the largest of the crypt of the tonsil, leads to peritonsillar abscess. Quinsy is also otherwise known as peritonsillar abscess. It's actually a collection of pus in the peritonsillar space. Peritonsillar space is actually this potential space which lies between the superior constrictor and the capsule of the tonsil. Peritonsillar space is actually a potential space seen lying between the superior constrictor and the capsule of the tonsil. It is usually unilateral. It commonly affects adolescent men. Currently, this peritonsillar abscess has been attributed to inflammation of Weber's gland. Weber's glands are nothing but accessory salivary glands which are seen at the superior pole of the tonsil. So, inflammation of the Weber's gland and suppuration of the Weber's gland leads to quinsy. That is a current accepted hypothesis. Let us go to the clinical features of quinsy. Patients are really ill. They are febrile. These patients are young adolescent patients, will have odynophagia, really painful swallowing. They won't even be able to swallow the saliva because of the fear of pain. So the saliva will be constantly dribbling from the mouth. The patient will have inability to open the mouth because of presence of trismus due to spasm of the muscles of mastication. And these patients will have muffled or hot potato voice. It's also known as rhinolalia clausa. Clinical examination of quinsy, the tonsil will be found pushed downwards and medially. When you use a tongue depressor to apply pressure, it will blanch on touch. Uvula is edematous and it is pushed to the opposite side. The tonsillar pillars are congested. The patient will have halitosis or bad breath. There may be trismus, enlarged jugulo-digastric nodes which could be painful on palpation. Management. Medical management. You can prefer using broad spectrum antibiotic. This is very helpful only in the stage of peritonsillitis, inflammatory stage only. If it develops into an abscess should necessarily be drained. So the antibacterial spectrum should generally include gram-positive, gram-negative, and anaerobes. So commonly used drugs are broad spectrum penicillin ideally, amoxicillin in combination with clavulanic acid, and in addition you can prescribe metronidazole or clindamycin to take care of the anaerobic infection. Then anti-inflammatory drugs and antipyretics can be given to alleviate patient's pain and fever. Surgery. Wherever there is an abscess, you need to do incision and drainage. The rule of thumb where you will incise is the point of maximum bulge, you incise. That is the general rule of thumb. The same thing will apply even to quinsy, but there is also another area where you can open the quinsy and drain the abscess. That is, you draw two imaginary lines, one horizontal and one vertical. The horizontal line can be drawn from the base of the uvula to the extending up to the anterior pillar, and the vertical line can be drawn along the anterior pillar of the tonsil. At the point of intersection of these horizontal and vertical line, you just insert the forceps, which is known as Sinclair Thompson Quincy forceps, and you can drain the pus from the peritonsillar area. And ideally, these patients should be advised to undergo tonsillectomy after 6 weeks after performing the incision and draining, because quinsy could recur anytime. Quinsy can recur anytime. Some authors prefer to do tonsillectomy along with quinsy drainage. Of course, it's a risky procedure. It is also known as hot tonsillectomy. It bleeds the most when you attempt to do tonsillectomy in these patients. Always better to do incision drainage, put the patient on a course of broad spectrum antibiotics, and then take up the patient for tonsillectomy 6 weeks after the incision drainage is over. Here is a video showing the quinsy being drained. Sorry. There is a video recording. Here you see the quinsy forceps being introduced, widened, pus being drained out. This is ideally performed in the 4% xylocaine spray. Anesthesia need not be given. If it is performed under anesthesia, there is always a chance of aspiration. Now let us come to chronic parenchymatous tonsillitis. This occurs following repeated attacks of acute tonsillitis. Chronic parenchymatous tonsillitis always occurs following repeated attacks of acute tonsillitis. The lymphoid follicles and tonsillar parenchyma are really hyperplastic. In these patients, the tonsil undergo huge enlargement and the follicles are not prominent. The infection is found within the substance of the tonsil. This is the ideal case for surgery, tonsillectomy. Now, membrane can form on the tonsil. It's also known as membranous tonsillitis. So this is actually a common question which is asked in your exam as short notes or during your clinics. The differential diagnosis of membrane over the tonsil. The membrane over the tonsil can be caused by membranous tonsillitis because of the drying up of the purulent secretion over the tonsil. It forms a yellowish white patch. Diphtheria can cause membranous tonsillitis. Vincent's angina can cause membranous tonsillitis. Infectious mononucleosis can cause membranous tonsillitis. Agranulocytosis can cause membranous tonsillitis. Leukemia can cause membranous tonsillitis. Aphthous ulcers and oral thrush also can cause membranous tonsillitis. Now, we will dwell a little bit into diphtheria. Diphtheria is a classic case of membranous tonsillitis. The membranous X-rays can be seen in the tonsil. It will be seen over the soft palate, and these patients will have toxic effects, distant toxic effects, including toxic myocarditis due to the diphthetic toxin. So there are 3 different strains of diphtheria which can be involved here: gravis, intermedius, and mitis. These organisms grow well in loveless media or tellurate media, and these organisms are known to ferment glucose. So this infection is very rare these days, but rarely we encounter because of the failure of immunization. The features of diphtheria, fossil diphtheria, will look like dirty white thick membrane, curd-like membrane, covering the entire tonsil, the base of the uvula and part of the uvula. The child will be very quiet. There will be weakness, lassitude, headache, fever, foul breath. On clinical examination, you can see grayish or yellowish thick membrane covering the tonsil, extending up to the soft palate and uvula. The membrane can be removed, leaving a raw undersurface. The cervical adenitis will be huge, so it will be known as, it is also known as bull's neck because of the enlarged cervical lymph node. So what are the investigations? You do a throat scan for culture insensitivity. You can do a lymphocyte count. If you do a lymphocyte count, you will find it to be raised. Albuminuria can be seen. Schick test is positive in this child. Differential diagnosis. It can be due to, you will have to differentiate diphtheria, fossil diphtheria from acute streptococcal tonsillitis, from oral thrush, from infectious mononucleosis, from quinsy. Now, complications of membranous tonsillitis include myocarditis and circulatory failure. This myocarditis is known to cause bradycardia. Usually, myocarditis is known to cause tachycardia, whereas in diphthetic myocarditis, the children will have bradycardia. There will be peripheral neuritis, there will be palatal palsy, there will be ocular muscle paralysis. The common nerve being involved is the lateral rectus due to, the lateral rectus muscle is commonly involved due to abducens muscle involvement. Peripheral neuritis is also common in this children. Let us come to the investigation of the patients with inflammation in Waldayer leaf. We can do a throat culture to identify or look out for the presence of beta hemolytic streptococcus. But the main problem is it takes nearly 48 hours for the result to reach your hands. And this test, ironically, cannot differentiate acute from chronic infections. The next investigation is you can do a rapid test, which is known as ASO titer. Ideally, if you are able to prove a 4-fold rise in titer in consecutive tests, then you can consider it to be significantly positive. So ideally speaking, you need to perform a test in the first week of infection, and then a week later you need to repeat the test again. And if there is a 4-fold rise in anti-streptomycin O titer, it goes without saying the child is suffering from beta hemolytic streptococcal infection. You can do a Paul Bennett test to rule out infectious mononucleosis. Then you can do a radiological evaluation of the nasopharynx, namely the X-ray skull lateral view taken with the extension of the neck. Extension of the neck focused on the nasopharynx area to rule out adenoid enlargement. You can do radiological evaluation, like CT scan evaluation of the nose and paranasal sensors to rule out sinus infection. Now, adenoid hypertrophy is known to cause nasal block, obstructive sleep apnea. I have already been focusing on the aspect of recurrent vomiting in children. I am not going to repeat it again and again. And these children will manifest with adenoid faces. The classic adenoid faces include underdeveloped thin nostrils, shortened upper lip, prominent upper teeth, crowding of the teeth, narrow upper alveolus, high arched palate, hypoplastic maxilla, loss of nasolabial fold, and an idiotic look. This is a commonly asked short nose and commonly asked oral questions. So adenoid faces you need to note it down. Let us go to the radiological imaging. This is actually the classic X-ray of the nasopharynx, focusing the nasopharynx, which is taken to assess the size of the adenoid. This is the enlarged adenoid you are seeing, compromising the nasopharynx airway. The green asterisk is the adenoid tissue. You can see that clearly the enlargement of the adenoid. The nasopharyngeal airway is reduced. The management, you go ahead and remove the adenoid by a process known as adenoidectomy. You use a St. Clair Thompson, you use a adenoid curette to remove the adenoid. The difference between tonsil and adenoid is another commonly asked question. A tonsil is 2 in number, adenoid is 1 in number. A tonsil is seen in the oropharynx, adenoid is seen in the nasopharynx, tonsil is encapsulated, adenoid is unencapsulated, and then tonsil has crypts, adenoid has furrows, tonsil is lined by squamous epithelium, adenoid is lined by columnar epithelium, tonsil has no efferent lymphatics, adenoid has both efferent and efferent lymphatics. The adenoid feels like a bag of worms when you palpate. So, medical management in this medical management is usually preferred only in acute adenotonsillitis. It is directed against aerobic pathogens, commonly against beta-hemolytic streptococcus. Penicillin is actually the drug of choice. Ampicillin or amoxicillin can be given in doses of 40 to 50 milligrams per kg body weight. Anaerobes have been implicated in patients with recurrent tonsillitis. Hence, clindamycin can be considered in treating patients with recurrent and resistant cases. Amoxicillin in combination with clavulanic acid can be used when ampicillin alone is ineffective. In children or adults where they have sensitivity, hypersensitivity to amoxicillin or reactions to amoxicillin, you can substitute with azithromycin. The surgery, you go over and do a tonsillectomy. Here, the classic surgical procedure to remove tonsil earlier, they used to perform a surgery known as by removal of tonsil using guillotine method. Guillotine method is actually in France. What they used to do was they used to chop the heads of the convicts to kill them. They behead the convicts using a guillotine. The same principle was used to remove the tonsil. There was a tonsil guillotome was designed for this purpose. The guillotome is inserted and the tonsil is held between the blades of the guillotome and it is chopped. But what happens is, this is actually a messy surgery. There was extensive bleeding after the surgery. So the guillotine method was abandoned. The currently used method is dissection and snare method using cold state tonsillectomy. This is the commonly used procedure in all your institutions. So this is a video clipping showing cold steel tonsillectomy being.
Tonsillectomy is a surgical procedure.
So here the patient is put in Sister Rose position. Sister Rose actually the operation theatre nurse who suggested this position. The uniqueness of this position is the neck is hyperextended and the head is also extended at the atlanto-occipital joint, and you place a sandbag under the shoulder of the patient to ensure that this position is held, and a small ring is placed at the head end of the patient, and the mouth of the patient is kept open using Waldayer mouth gag. This is actually a tooth forceps or valsalum, which is used to incise the mucosa medial to the anterior pillar incised using a valsalum. The tonsil is seen being held by a tonsil holding forceps or a tenaculum forceps. Tenaculum means capsule. So tonsil is being held by a tonsil holding tenaculum forceps. And you see bottom ball is being used to lift the tonsil, push the tonsil away from the tonsillar fossa and tonsillar bed. The tonsil is dissected away from its capsule along with in the capsular plane. The plane is very important. If you are in the correct plane under the capsule, you should be able to perform the surgery without any bleeding. So you see the tonsil is lifted out of the tonsillar bed. The tonsillar fossa is packed with cotton. The entire tonsil is free, lifted away, just attached at the lower end, lower port. You see the eave snare being introduced. Snare wire is clearly seen, and you snare the tonsil, cutting it out. Advantage of snaring is it crushes and cut, thereby reducing the bleeding. When you press the tissue thromboplastin is released, thereby promoting coagulation. Now you see empty tonsillar fossa without any bleeding. Now let us go to another surgical procedure, the coagulation surgery. Again, another way of doing tonsil, removing the tonsil. See here, instead of the valsalum, you use a coablation band, tonsil band. It's cold ablation. Normal saline will be irrigated through the probe. This is actually a cold dissection. There's only very minimal bleeding. You see the bleeding is as if it's more because the entire video was shot under microscope. So you are seeing a magnified image. It's nearly 5 times magnified. Whenever there is a bleeding, all you got to do is touch that area with the van, press the pedal, it will coagulate. You see the tonsil being slowly removed, lifted out of the tonsillar bed, slowly removed. The bleeding is very minimal. The tonsil is removed totally. You can remove the tonsil as close to the posterior tongue as possible, as close to the tonsillolingual sulcus. So that is the tonsillolingual sulcus area. That is where bleeding will be more in normal conditions. And in other, if you use other techniques, the bleeding will be more. In cold steel tonsillectomy, that is where the bleeding will occur commonly from the lower area, lower port, where the blood vessels from the tongue creeps into the tonsil. So you start dissecting the tonsillolingual sulcus, removing the tonsil totally. So the tonsil totally removed. How close to the tongue I'm working, you see. Surgery is over. Suction is applied. You see a free force. Same process is repeated on the opposite side. Let us not waste time repeating it. RF cartridge. This is again another way. These are the various types. You have seen the cold slit tonsillectomy. You have seen the coablation tonsillectomy. You are going to see RF tonsillectomy. Laser tonsillectomy is currently large number of ENT surgeons are taking up the laser tonsillectomy. You can use ultrasonic waves to do a tonsillectomy. It's called harmonic calcium tonsillectomy. Now let us see how we do tonsillectomy using a radio frequency probe. The radio frequency probe is actually a forceps. You use alternative pinching action to coagulate and cut the tissue. So you see the tissue being pinched. Whenever you press the pedal to coagulate and cut, you see distortion on the screen. That is because I've been using a TV monitor, because a medical grade monitor where this distortion will not be seen is a little bit expensive. So it's actually a compromise. Started using a TV monitor rather than a medical grade monitor. You see the pinching movements, alternate pinching movements. When you do a coablation tonsillectomy or a cartridge tonsillectomy, you need not apply any ties or sutures to stop bleeding, because the procedure itself is bloodless. The fumes which comes out during cautery will have to be immediately sucked out by an assistant holding the suction. Otherwise, the visibility will be obscured. See, the tonsil being cut as close to the tonsillingual sulcus as possible. There's virtually no bleeding. See the alternate pinching movements which you apply to the forceps to cut. The moment you pinch the tissue, it cuts, coagulates and cuts. The fossa is totally bloodless. You don't see any sutures, you don't see any ties applied. See, both tonsils are free, no bleeding. Now let us dwell a little bit deep into the indications of adenotonsillectomy. The indications include infections, obstructions, and other indications. Infections, this is actually a broadly used conditionalities. Under infections, recurrent episodes of acute tonsillitis. How recurrent? More than 6 episodes per year, or 3 episodes a year for more than 2 years. I repeat again, recurrent attacks of acute tonsillitis, more than 6 episodes a year, or 3 episodes a year for more than 2 years. So recurrent episodes of acute tonsillitis associated with other conditions like cardiovascular disease, recurrent streptococcal tonsillitis, child with recurrent febrile seizures, because tonsil infection can cause fever, and every time the child gets febrile seizures, some area of the brain will be damaged. So it's always better to prevent the recurrence of febrile seizures. That can be done by removing the focal sepsis, doing a tonsillectomy. And chronic tonsillitis that is not responding to medical management, that is associated with halitosis, persistent sore throat, cervical adenopathy. These are all the indications for adenotonsillectomy. Streptococcal carrier state, which is unresponsive to long-term penicillin management, again you can go and do a tonsillectomy. Quinsy, after draining quinsy, you can go and do a tonsillectomy. Tonsillitis associated with lymph node abscess, it's an indication for tonsillectomy. Infectious mononucleosis with severely obstructing tonsil, kissing tonsil, which is not responding to medical management, is again one of the causes for adenotonsillectomy. In children, it is always better to remove adenoid along with tonsil while you perform tonsillectomy, because when you remove tonsil alone, adenoid will undergo compensatory hypertrophy. So it is always better in children to do adenoidectomy and tonsillectomy in unison rather than tonsillectomy alone. What are the causes of obstruction which will provoke you, to do a tonsillectomy? One is sleep apnea, then adenotonsillar enlargement associated with carpal nerve, dysphagia, speech abnormality, namely rhinoceros plaza, craniofacial growth abnormalities, occlusion abnormalities. Commonly, children will be taken to a dentist for dental correction due to occlusion problems. The dentist will promptly refer the patient back to you, saying that you need to remove the adenoid and tonsil for me to do the dental correction. So, in all cases of occlusal abnormalities, you need to look for the adenoid and tonsil enlargement. If they are enlarged and infected, you will need to remove them. The other causes include embedded foreign body. If a foreign body is embedded in the tonsil, don't go ahead and pull the foreign body out, because tonsil is highly vascular area. So the foreign body can cause enough damage and it can lead to bleeding. So it's always better to remove the tonsil along with the foreign body. That's the safest way of removing a embedded foreign body within the tonsil. And then cysts inside the tonsil can always be removed along with the tonsil by doing a tonsillectomy. Tonsillectomy can be done in order to secure access to tonsil bed structures, which can be an elongated cellular process which you want to remove because it's causing pain, Eagle syndrome. So to remove elongated cellular process, you need to access the tonsillar bed area. You need to violate the tonsillar bed area. If you want to violate the tonsillar bed area, you need to remove the tonsil to expose the tonsillar bed. Then if you want to coagulate, or if you want to tie the glossopharynx, if you want to cauterize the glossopharyngeal nerve to prevent pain occurring from the area, glossopharyngeal neuralgia. So you can access glossopharyngeal nerve using via the tonsillar bed, reaching the tonsillar bed. For that to happen, you need to remove the tonsil. Then if you want to gain access to the parapharyngeal space to remove tumors arising from that area, you need to remove the tonsil to get access to the parapharyngeal space via the tonsillectomy. Then the complications of tonsillectomy can be classified as immediate complication, intermediate complication, and delayed complication. Immediate complication which occurs on the table, which can be bleeding, trauma to the pillars, trauma to the anterior pillar will cause asymmetry of the fossa, trauma to the lips and gums and teeth again can be seen. Intermediate complications involve reactionary bleed and primary bleed. So reactionary bleed occurs when the effects of anesthesia has worn out in the immediate post-operative period. And primary bleed again is caused by bleeding on the due to slippage of ligature. Primary bleed is caused due to slippage of ligature. Reactional bleed is caused due to wearing out of the effects of anesthesia. Then delayed complications include secondary hemorrhage due to infection. If there is secondary hemorrhage, it occurs after the 7th day. Antibiotics should be given to these patients to tackle the infection. Bleeding in the immediate intermediate stage, you need to secure the bleeding by tying or cauterizing the bleeding. That's it. Thank you so much for patient listening.